Hi, welcome to UCLA and the David Geffen School of Medicine here at the Ronald Reagan UCLA Medical Center. My name is Isaac Yang. I'm an associate professor in neurosurgery and head and neck surgery, and we're really glad that you can join us here today. We're going to have a conversation with Dr. Quentin Gopin.
Thank you, Dr. Yang, for the kind remarks. I am Quentin Gopin. I'm an associate professor in head and neck surgery with a joint appointment in neurosurgery. And it's my pleasure really to be here and talk about a condition that's near and dear to my heart, superior semicircular canal dehiscence. And we're going to go through this lecture, and I leave it to you.
So yes, Dr. Gopin and I lead the Superior Semicircular Canal Dehiscence program here at UCLA, and we're just going to have a conversation about SSCD. Superior Semicircular Canal Dehiscence. It's a mouthful, and so we're going to just try to refer to it as SSCD. And SSCD was actually originally founded by Dr. Lloyd Minor in 1998 by a head and neck surgeon. Dr. Gopin?
Yeah, he really discovered the condition from failed ear surgery, and we now know it is from an abnormal bony covering of the inner ear. And it can be diagnosed now with CAT scans, which is part of what we'll be discussing in the subsequent slides.
And that condition was otosclerosis, right?
Yes, that's correct. They thought that patients had hearing loss due to a different condition called otosclerosis, and when they went in to try and fix it, the surgeries failed, and then Dr. Minor was able to associate the CAT scan findings of canal dehiscence in that group of patients.
That's pretty ingenious of Dr. Minor to elucidate or parse out SSCD from a patient who they thought had otosclerosis.
I think that was a big leap, because up until that point, no one knew what was going on in these patients, and it's quite a few patients, as we have found.
Yeah, and Lloyd Minor went on, and he's now currently the Dean of Medicine at Stanford Medicine. So SSCD, what is SSCD, Dr. Gopin?
So normally your inner ear should be completely sealed in bone, and in some individuals, for unclear reasons, that bony covering is not present. The bone is always, even in normal patients, very thin, maybe millimeters in thickness, but in this condition it becomes an abnormal opening, and the medical term for opening is dehiscence. And so you get an abnormal opening into that balance chamber, and it causes a variable degree of hearing problems and balance dysfunction amongst other generalized symptoms.
How big is this hole normally?
It's pretty small, usually on the order of a few millimeters in size.
Yeah, we've done studies. Dr. Gopin and I here, we've done about over 190 superior semicircular canal dehiscence repairs. And we've used this computer technology that we have at UCLA to do semi-automated volumetric assessment of these SSCDs. And we found that in average, our SSCD dehiscences are roughly somewhere between 7 and 9 millimeters as our average size of how big these holes are. But these holes are really, really small, and they're holes between the inner ear and the brain cavity, and these holes are really small, but these small holes can cause big problems. What are the problems that we normally see with SSCD, Dr. Gopin?
So you can divide them into auditory dysfunction, which is another medical term for hearing dysfunction, so hearing loss of various types, hearing abnormal sounds, so a lot of internal amplification of sounds like your heartbeat, your own voice, digestive sounds, amongst others. And then balance and dizziness problems is another big category. So those symptoms are dizziness or vertigo, which is an abnormal spinning sensation. The eyes kind of bounce around in a jumbling of the panoramas called oscillopsia. That can be present as well. And then the final classification would be just sort of generalized complaints, which most of the patients, I think you would agree, have headaches and ear pressure from this condition as well.
So these patients hear their own heartbeats?
That's correct. So they hear their heartbeat in the ear that's affected, and it's quite bothersome to them because obviously they're not able to kind of enjoy the usual peace and quiet with that background.
And they hear their own voices?
When they talk, their voices and echo inside their head. The medical term for that is autophony.
So they hear their own voice, they hear their own heartbeat. Are there any other strange body sounds that they hear?
Sure. Some patients have reported hearing their eyes move inside their head, digestive sounds. Even when they walk, they can hear their own footfalls amplified. Pretty much anything you can think about, jaw, joint movements, any neck movements, those are all internally amplified. And the concept is that in your inner ear, you have a normal entrance, which is the first window, and an exit, which is the second window. And in this condition, there's an abnormal exit for sound, which is termed a third window, and the general classification of third window lesions is given to this condition.
Yeah, I think the most common thing that we've heard from the sound standpoint is that people say they hear their own heartbeat, they hear their own voice, they hear their own neck muscles move, eye blinking, eyeballs move, footsteps, those happen. And then what are the vestibular symptoms associated with SSCD?
Yeah, they're just generalized problems with balance and dizziness, feeling off, but particularly with loud sounds. And so if there's any kind of a loud sound that then induces dizziness, that is a little more specific for the condition. So when some patients are firing a weapon, then they get a real kind of wave of dizziness, or if a car beeps at them, those sorts of symptoms are suggestive of canal dehiscence.
And the last thing that you mentioned was cognitive issues or headaches or earfulness. Can you talk a little bit about that?
Yeah, a lot of patients with dizziness and balance problems will report fatigue and difficulty with energy. A lot of patients say brain fog, just sort of a general, I don't know, just lack of crispness or difficulties with memory, things that are not specific. Obviously, there's a lot of causes for brain fog or fatigue, but when you start combining on that list the hearing things that we talked about and balance things that we talked about, even before you get the CAT scan, you can build a pretty good case that it's likely that this person has canal dehiscence because those symptoms are pretty specific to this condition.
Dr. Gopin is an ENT surgeon, a board-certified ENT surgeon, really one of the best ENT surgeons in the whole country. I'm a neurosurgeon. I'm a board-certified neurosurgeon, so we're different specialties. And so we're bringing a multidisciplinary, multi-specialty approach to SSCD. And so I get this question a lot also, which is about brain fog, since I'm the brain surgeon. And so they ask about brain fog. And the way I like to think about the brain fog is that if you have SSCD and you hear heartbeat, you hear voice, you hear all these secondary sounds all the time, your brain is working twice, 3, 4. It's working harder than people who don't have the disease because they're trying to block that sound out so they can try to live their normal life. Or if you have SSCD and principally your symptom is balance problems, one of your ears is giving you bad balance information because of SSCD, and the other ear is either giving you bad balance information because of bilateral SSCD, or it's giving you good information, your brain is working overtime trying to figure out which one of this is good information, which one of this is bad information, and because you're using more of your brain energy, you don't have as much brain energy left to do your normal routine tasks. What do you think about that?
No, I agree completely. It's just like a computer that's working hard with a background virus. It doesn't have enough memory to process what's important, and I think what you said is spot on.
Yeah, and so if the virus is SSCD, then the treatment for the virus is surgery.
Yeah, that's correct. Although there are some medications that can kind of treat some of the symptoms in a way that's not direct. Surgically repairing that abnormal entrance into the inner ear is, I would say, the standard of care way that this condition is treated.
And so here at UCLA, Dr. Gopin and I, we do the most SSCD cases here at UCLA together, and we've done over 190 superior semicircular canal dehiscence repairs. Let's talk a little bit about these patients, Dr. Gopin.
Yeah, so here are some of our statistics. You can see that we have a slight predominance for women, roughly 63% in our own series, and the age ranges from the teenage years up into the late 70s with a mean age of about 55. And we have, based on our own patient series, been able to gather some factors that seem to be weakly associated with the condition. So we have identified osteoporosis, or at least I should say others as well have identified osteoporosis to be a weak linkage. Trauma to the area, whether it's barotrauma, meaning pressure from scuba diving or flying, or actually an event that caused some trauma to their head where they lost consciousness or had a fracture. Those things are associated. Even things like childbirth can be a causative factor, and then thyroid dysfunction. So we've been able to identify some associations with thyroid disease based on a review of our own patients.
Yeah, and I think this is a point not to be overlooked, is that this is a really rare disease. And so if you're only doing 1 or 2 cases a year, it's really hard to parse out some of these concepts. But Dr. Gopin and I, we're doing research on SSCD, and we have grant funding and funding mechanisms to help us do this research. And we do somewhere almost 60 cases of SSCD repairs a year. And when you see that many number of patients, then you can start seeing some of the population statistics and some of the more larger picture conditions and situations when it comes to SSCD. So the first thing is, it appears that's more common in women than men.
Yeah, I agree, and I think that's an extremely important point, which is that we really don't know the cause of this condition, and the more information we can get you would hope at some point we can do other things besides surgery, like a medical cure. But even gathering information for triggers and avoidance and the natural history, those are all relatively unknown parts of this condition. Patients often will ask, well, is this going to get worse over time, or is there any chance it's going to get better? And it's difficult to answer a lot of those questions just because it's a relatively new condition, but the more interested we are in following these things, the bigger the series, it helps to give patients better answers to those questions.
Yeah, and I think it makes sense that it's more common in women than men because it's a condition that the base of the skull is getting thin and thinned out, and eventually it becomes a hole. And if you look at bone conditions, which gender has more bone conditions or thinner bones, like osteoporosis, as 10% of our patients are correlated with. And as we look at the bone metabolic markers, I would think that bone calcium is more of an issue in women than men. And so it makes sense to me that's more common in women than men.
Yeah, and I think the literature has bore that out as well.
And it looks here that there's a pretty high percentage of patients that are associated with trauma. What do you think about trauma in SSCD?
Yeah, I would say that that's something that we come across. I would say our series, 27%, is probably a little on the low side. I think it seems to be, depending on how you define trauma and things of that nature, but a lot of patients will report an anecdotal history of something that kind of started them off that was a traumatic event.
And the average age is 55. Would you agree that SSCD is something that presents commonly, and not always, but most typically when you're around 40, 50, or 60 years old?
Sure, no, I think that's fair. I think pediatrics are different. Their brain accepts things, and so they're not going to report symptoms the same way as an adult is. And so even if some of the children are coming down with this condition, you might not have the same type of presentation. But certainly in our experience, I'd say that's about accurate.
Yeah, and Dr. Gopin has published a paper on pediatric SSCD in the Journal of Neurosurgery. And you can see that our youngest patient is 17. I still remember doing that. And our oldest patient was 79. So that's the age range. But I would say, yeah, the vast majority of patients are around 55. And so we have these symptoms, pulsatile tinnitus, patients hear their heartbeat. You have some decreased hearing because of that, and the autophony and the hyperacusis, and the sounds of internal amplifications, as we mentioned. Is there any other symptoms you think that are sounds that we aren't relaying here?
No, I think it's a pretty good list. Hyperacusis just means you're more bothered by loud sounds than you normally would, but no, I think it's a sufficient list.
Yeah, and I think this description doesn't adequately describe some other things. So when they hear their own heartbeat, if you have SSCD and your heartbeat goes up because you get excited, scared, or nervous, or any situation that makes your heart beat faster, you're going to hear pulsatile tinnitus a lot more. Is that correct?
Yep, absolutely.
Yeah, and I also think it's blood pressure related. So if you get more anxious, nervous, or you exercise, start lifting weights, or you go running as your blood pressure goes up, perhaps your autophony will get worse.
Yeah, I think just like any other kind of flow-related phenomenon, the more flow, the more robust, the louder it's going to be, and you're just going to hear that a little more prominently, so yes.
Yeah, and so you also get balance problems. Tell me about the balance problems you get with SSCD.
So you can kind of divide them into different classifications in terms of if they're provoked or not. So if provoked by a loud sound or a pressure event, a little more specific to the condition than the ones that aren't provoked, but certainly plenty of patients have difficulties with balance, disequilibrium, and depending on whether they have the condition on one or both sides will really kind of dictate how impacted they are by that. But in the severe form, these patients are incapacitated. They cannot work, and basically they are not able to function because it's so disabling.
Now let's talk about the different symptoms. Do you always get the sound symptoms? And do you always get the balance symptoms? And do you always have to have both?
That's a great question. So it just, I think, shows how little we understand really what's going on. So some patients have the full normal spectrum. They have the hearing problems, the balance problems, all the symptoms, and they're fairly straightforward. But there are certainly a pretty big group of patients that have only auditory systems, meaning they only have the internal amplified sounds, and they have little to no balance problems at all. And then you have the exact opposite, where you have some patients that are primarily dizziness oriented, and they have very little hearing or internally amplified sounds. And some patients actually have better than normal hearing, and their hearing isn't impacted at all. So obviously there are factors that we would like to uncover, but as of yet, no one has really figured out why some patients present in certain ways compared to others.
So we know very little about this disease because Dean Miner, he initially discovered this around 1998. And so we have only had a term for this for the past 20 years or so. But you're saying that there's different subtypes of SSCD, essentially.
Yeah, I think the presentation can be variable, and that's what makes it a little trickier, but we do have ways of sorting it out, which we'll go through in the chat.
Sure. So for SSCD, there are different subtypes that you have auditory and balance problems. And then there's a second subtype, which is just having the auditory symptoms. And then there's a more perhaps rare subtype, but still a sizable subtype that only have vestibular symptoms.
Yes, I agree, and I think part of that may be depending on how the hole is present versus if there's maybe a thin covering of bone. So we've started to realize that even if you don't actually have an opening into the bone, if the bone is thin enough, you can start to leak sound energy and that sort of stuff, and that can cause some symptoms. And maybe that's why you don't get the classic full presentation, but still that's all a relatively new concept.
Yeah. You know, the analogy I like to use for that sound concept is if you live in an apartment and the apartment has thin walls, and if your neighbor is noisy, if there's a hole between the wall, you're going to hear them better. But if the wall is thin, if your neighbor is noisy, you're going to hear them through the wall.
Some of it's going to come through. That's a good one.
And then let's go through the last one, which is other symptoms: headache, fatigue, brain fog. What do you think about this in SSCD?
You know, I think whatever it is that's causing this bone to become missing, disintegrating it, if you want to think about it that way, is probably a painful process, right? That bone is supposed to be there, just like if you broke your arm or your leg, it's a painful process. I assume that condition that's driving that bone to become resorbed or disintegrated is causing pain, and the headache that we see is, I think, from that. Fatigue is probably from more of the balance and dizziness issues, but we already talked about the memory issues and the brain fog, but I do think that the pain is coming from that, and some patients are given a diagnosis of migraine headaches or things of that nature, but I really think it's the etiology of what's going on with the condition that's causing that.
Now, what you're referring to is something called migraine-associated vertigo, MAV, or migrainous vertigo, vertigo-associated migraines.
Right, that's a somewhat separate diagnosis. That's not part of canal dehiscence, where people can have attacks of vertigo, and there's associated with that migraines. Obviously, not all of those patients, or even a chunk of them, are going to have canal dehiscence, and so that's a relatively non-specific complaint if someone says, oh, I have headaches, and then I'm getting dizzy. But as soon as you start adding some of those other symptoms to the milieu, or if you have a test that confirms the dehiscence, then we know what's going on.
So I'm sorry, let's just be clear with that. How do you distinguish, as a SSCD expert, as a world expert, world-class ENT surgeon, how do you differentiate SSCD from migraine-associated vertigo?
So I would say the gold standard for the diagnosis of semi-circumferential dehiscence is a CAT scan. So a CAT scan shows the bony anatomy very precisely, and you can see the area in question. You can measure the thickness of bone or identify the size of the opening. So a high quality CAT scan, which is 0.6 millimeter continuous slices, is going to show up that defect, and if that defect is present, your diagnosis is confirmed. Now, there are some functional tests that can be done that do help with that. One is called the VEMP test, and we'll get into it a little bit, but that is an abnormal reflex that can help confirm the diagnosis. And so if there's some question about symptoms or the CAT scan is unclear, that can be helpful. But once you have the collection of symptoms that are pretty specific to the condition, and you have a CAT scan that shows that dehiscence, I would say the diagnosis has been made and you know what's going on.
So, like you just said, the way to diagnose superior canal dehiscence is a CT scan?
Yes, a CAT scan. So coronal views is the best plane for finding that. They do also have some fancy reformatted views. One is called a postural view, where you're imaging in the plane, but you can certainly see it on a standard coronal view, and we'll go through some images here and show an example of that. So these are going from the front to the back of the head, and the bone is going to be white on the scan. So why don't we go ahead and look at that?
Sure. So this is a CT scan here.
Yeah, this is a CT scan, so this would be the kind of the side of your skull. This would be the floor of your skull. This is the carotid artery and the cochlea. And as we kind of start to pan through the images, you can see this little gray tube sticking straight up. So that's the superior semicircular canal. This is the lateral canal sticking sideways, and there's the channel where the nerve is plugging into those. And this canal here should have a nice white covering of bone over it. And you can see here clearly the canal is open, and the brain, which is the gray structure above there, is not divided by any kind of a bony plate. And as we follow the scan all the way over to the far side, we're going to start to pick up the bony covering again. Once we get all the way to the other side here, it's still a little dehiscent, but if you go here, that's what it should like all the way across. If you go back, yeah, there should be a nice white bony covering over the entire canal.
So in your mind, if you have the clinical history and the patient presentation of SSCD SSCD-like symptoms, and you have a CT scan that shows a canal dehiscence, you think that's the diagnosis for SSCD?
Yeah, I'd be comfortable giving someone the diagnosis. I think the VEMP testing is reasonable. It can help you, especially if you're going to compare it with the post-operative result, if the results are not what you're expecting or there's something unusual, or if the symptoms are unusual. But if you have, internal amplified sounds and sound-induced dizziness and all the classic kind of symptoms and a CT scan that looks like that, you know that the patient has canal dehiscence.
How do you know that this patient doesn't have migraine-associated vertigo?
It's possible that these things are comminglers, and maybe this condition is irritating the lining of the brain enough that they end up getting migraines, and then those are then causing dizziness and balance problems as well. That's an unknown, and there are a lot of practitioners that will treat patients for migraine-associated dizziness problems, even though you know that they have this condition. But I do feel like a lot of it is coming from the normal balance chamber is not able to function properly because it's not sealed, and obviously that's going to cause a lot of dizziness and balance problems.
What percentage of people do you think have this CT finding and a canal dehiscence, but don't have any symptoms of any sort whatsoever?
There certainly is patients that fit that criteria. So sometimes when you're looking at scans for other purposes, you can see what looks like a dehiscence and why they're not having more symptoms. It's unclear, but I'd say it's a minority. It's a rarity. When I see that scan, and obviously I'm biased because patients are coming to see me with symptoms, so I don't know if you start scanning just run-of-the-mill people how often you'd come across that abnormality. But the CAT scan does have a finite limit of resolution, and I'm sure with some signal averaging you might be able to see a little opening there when there really isn't one there. But I would say for the most part that's a pretty rare finding.
Great. And so you think that this Poschel's view is of particular use in diagnosing SSCD?
It's something that was developed to just try and show the entire dehiscence in one fell swoop. So rather than going sequentially through the scans, as you can see here, there's just one scan in the plane of the canal. So you can see here's the bony covering, and it just becomes missing from there to there. So you can give kind of a snapshot view. But that's something that's not routinely done as part of the CAT scan. So for most CAT scans that are going to be done around the country, you're going to have the coronals, which are perfectly fine as long as they're high quality. But you can reformat into this Poschel view, and you can see the dehiscence quite nicely there without too much difficulty if you have that scan available.
So if I'm at home and I have these symptoms and I want to get a CT scan and I want to get it to diagnosis or rule this in or rule this out, at least get some answers because I'm suffering, what's a high-quality CT scan that I can ask my doctor to order?
Yeah, so it's called the CT of the temporal bones. So that's the area that we're interested in. The CT scan's always going to be of both ears, so there's no way to scan just one side. And that CT temporal bone, as I mentioned earlier, is going to be 0.6 millimeter slices continuous. And so sometimes to save data, they'll skip slices, and you don't want that because then you're going to skip over there. You want continuous set of data, which is sort of a standard way of doing the CT temporal bone. You do not need contrast. So contrast is a dye that's given to help show tumors and things of that. When we do a CAT scan to look for a canal dehiscence, we do not require that contrast be given, just a plain CT scan.
Fantastic. When do you use audiograms to diagnose SSCD?
So I would say all patients should have an audiogram. It's an assessment of the hearing, right? So we want to know if they have hearing loss. There are some features that on canal dehiscence, you can have an elevated nerve line or the so-called bone conduction line, and that's an example here. So 20 is considered the normal bar, and here a lot of the thresholds are elevated, and that's something that is very suggestive of the diagnosis as well. But this particular patient is hearing down lower around 35 or 40 decibels, and so the difference between where they should be hearing and where they are hearing is coming from that loss of sound energy in the condition.
And this initially was described by Dean Miner in a subset of patients who he thought had otosclerosis. Is that correct?
Yeah, if you can see this gap between where they should be hearing and where they are hearing, makes you think that there's some mechanical type hearing loss. And so people would go in and try and explore the ears for hearing bone problems, assuming that that was what was causing this problem, but in actuality it has nothing to do with the hearing bones. And so we do see from time to time people that have been referred to us that on the scan clearly have canal dehiscence, but had a procedure done to try and fix a hearing bone problem that actually didn't exist.
So do you think there are still people today in 2018 who are being diagnosed with otosclerosis when in actuality they have SSCD?
We do see that from time to time, yes.
And then you mentioned the VEMP test. What does VEMP test stand for? What is VEMP, and when do you use it?
So VEMP testing stands for vestibular evoked myogenic potential testing, And it's basically a reflex that you can test for in all patients. And so the concept is that when you turn your head and contract your neck muscles, there's a tonic signal being sent. And in a normal patient, when you get a loud sound into your ear, it actually sends a little brief inhibition of that tonic contracted signal. So you put some stickers on, I think we have a slide of it, onto the neck muscles. You have the patient turn their head to the side and put some loud sounds into their ear, and you see at what point they have that normal reflex. It was discovered in semicircular canal dehiscence that that reflex is very exaggerated. And so you can see here in the SSCD, at even low volumes of sound, 45, 50 decibels, they're getting a nice response, whereas in the normal configuration, you're getting it at the normal, much higher volumes, more like 90 decibels.
Now, I'm not an ear surgeon. I'm just a brain surgeon. And the way I think about this is your semicircular canals are your balance organs. So they're helping to keep your head steady. And so if you play a loud enough sound in your ear, all that system will go haywire and your neck will move. And so if you play a loud enough sound, even you can make my neck muscles move or your neck muscles move. But in canal dehiscence, SSCD, you play a normal sound and you get that reflex?
That's right. You're getting some responses that are much lower volumes of sound because of that abnormality. That's the concept.
But you said earlier that this is something that's not necessary or optional or side. How is this used when you diagnose a patient with SSCD?
Well, I think medicine is very much tailored to each individual patient, right? So I don't think there's any way that you can kind of come up with a global, this is what everyone has to have. You look the patient over, you examine them, you hear their story, and then you come up with a customized set of testing to give you the answers that you need to take care of the patient. So in some individuals, it's helpful, and I do think that it's a fairly easy test to get done. It's not invasive, but it's not a requirement that everyone have it. And I do think that it's something that it's helpful, and I have no issue with obtaining it, but I don't require that it be done before we head to surgery in all patients.
So I've been his partner here for almost 10 years now, and so I think what you like to do here is you want to treat every patient uniquely. Every patient is different. I'm different from you, and you're different from me, so my SSCD will be different from you, and so you diagnose each patient uniquely. And I think when I've seen you use it is when the hole is really small, or if there's no hole visible and it's just thin bone, and perhaps there's just a small crack, or you can't see a hole on CT scan and there's a small crack that you see. Is that when VEMP is most useful?
I'm not sure. I think probably. I do think post-operatively can be helpful too. If you do the repair, it should normalize, and then some people say, well, geez, if you don't have it to compare before surgery, I say, well, if it's still abnormally big after surgery, then I would say there's a problem, and that person probably should have a revision. Whereas if it's normalized, it doesn't really matter to me what it was like before surgery. I wouldn't make a big change in my care based on the VEMP testing, and I think
I think what you're saying is if someone has all the classical symptoms of SSCD and a very clear hole on a CT scan, but a VEMP test that's normal, you'll still offer intervention?
Sure, that's right. The VEMP testing is very test-specific, meaning who gives it is something that is variable enough that I wouldn't let it change our strategy just based on that one piece of information. I think you have to kind of take all the information together and come up with a idea as to what you think is going on. But that's right. If that scenario came to play where patient had classic symptoms, the CAT scan confirmed it, and they had a normal VEMP test, I would still proceed with surgery.
So you think the VEMP test is variable based on who's administering the test, which tech is giving it, which hospital you give it at, what day of the week it is, air pressure, the weather? Do you think VEMP test is variable like that?
Sure, I would say yes, and I also think based on the patient, some people have a reduced, reflex. It's just
based on the patient?
Right. So their reflexes may just be different, right? So just like your knee reflex is more robust in some patients than others, some people are going to have a more robust response to the VEMP testing. So just like everything else, it's a piece of the puzzle, but it's not the entire meal.
Yeah, and I would agree with that as a neurosurgeon who tests reflexes often. Some people's knee reflexes are very brisk. You just touch them and their knees kick out. Other people, I'm hammering away at the knee where I'm afraid I'm going to hurt them and their knees don't move. And they're perfectly normal and fine without any issue. It's just the spectrum of human being that every human being is unique and different.
For sure.
What is an ocular vent?
So it's the VEMP testing that we just described is called cervical VEMP testing. And
Cervical VEMP,
right,
okay.
that's the more common.
Or C-vemp, as some
C-vemp,
people
right,
say.
a small C in front of the VEMP, just like there's a small O there. And I would say that the cervical VEMP is more commonly done and easier to administer. But there have been some papers that purport ocular VEMP testing, which is the same concept. Instead of looking at the neck muscles, you're now looking at eye movements with sounds. And in this particular reference, they do claim to have a more specific and sensitive result with that. And it's just another way to do it. But most places don't offer ocular VEMP testing. Cervical VEMP testing is not offered at a tremendous number of places, but is certainly more commonly done than ocular VEMP testing.
But we still don't know because it's such a rare disease that needs a lot more research.
Yes, I would agree.
How do you treat SSCD?
Well, medically, you don't have a lot of great options. You can try and suppress the dizziness with non-specific agents. You can give anti-nausea medicines. You can give some over-the-counter and other type of medicines for the ringing in their ear and things like that. You can try hearing aids, although they're pretty unsuccessful because the louder you make the sounds, that kind of bothers patients with this condition.
You can try hearing aids?
You can, and some people do okay with them, but for the most part, I've had, I would say, not the best results with amplification of sound in patients that have canal distance. So I would say the standard of care is surgery, and there are different surgical approaches that have been discussed, and we'll run through those, but one is the so-called, if you go back one slide, sorry, is the round window procedure. That's the least invasive, and then going through the temporal bone, the ear from below, called the transmastoid approach, and then the one that we prefer, which is the middle craniofossa approach, is the one that's the most direct, going in from above, where you can see the opening the easiest.
Do you think all patients with SSCD should have surgery?
No, I think it's just the patients that are symptomatic enough, right? So if the symptoms are minimal and they're otherwise dealing with it well, then we observe that, and that's very reasonable. We don't know what the future is going to hold, and so the patients are always anxious about, will I get worse or not? I say, well, if you do get worse, we can always change what we're doing. But certainly observation is very reasonable, and you can try and treat the symptoms with medicines. But for many patients with this condition, they are overwhelmed by it, and I do think that they're looking for a solution, and we do have surgical options available to them.
What in the world is round window repair?
So that's the normal exit point. So when sound energy enters your ear, that's the oval window, and when it leaves, that's something called the round window. You can actually put a little patch over that exit point and change the dynamics of how sound energy and balance waves are flowing through the ear.
A patch? What do you mean? Like a Velcro patch, a skin patch,
just
plastic?
Tissue from the patient. So
Okay.
you take a little subcutaneous tissue and you plug it in there, or a little inflammatory tissue like gel foam, and you put it in this little window, and it stiffens it so that you're changing the compliance, the resistance of the system. And in some patients, that does change their symptoms for the better, and some very brief case reports have been written up about that. But it's really not addressing the fundamental problem. It's not putting the ear back to where it should be at the beginning. And in my view of surgery, you should really try your best to get things back to the normal situation more than alter it or change it. But for some patients that are too frail for surgery, that's a very easy procedure to undergo. This is something that's done through the whole of the ear. You go down into the ear canal and push the eardrum out of the way. It takes about 45 minutes to do it. It's an outpatient procedure, very minimal.
And so you do round window repairs here
Certainly.
at UCLA?
Yes, we offer that.
And in your opinion, do you find that it often helps with SSCD?
It's pretty variable, but I would say the results have been not that encouraging. And so the small handful numbers, and I don't have a tremendous data set to fall back on, but it's been variable and I would say not the best results with that procedure.
What's the transmastoid approach?
So that's a way of approaching the dehiscence from below. So understand, if you think about the dehiscence as almost like a volcano with the opening at the top of the mountain, you're really trying to fix it from the base, which is awkward. It's not designed for that. And in order to get there, you have to drill out the mastoid bone, which is a standard ear procedure. But at that point, you can't see that opening. So you either have to drill into the canal, which is, I would say, very invasive. Drilling into the balance chamber is something that's not tolerated well by the inner ear. It's a very delicate structure. And it's also difficult to get the repair wherever the dehiscence is without seeing it directly. And so we've come across a number of patients that have had attempted repairs by the transmastoid approach where clearly the repair did not get to seal the hole properly. And so in my opinion, again, I want to give myself the best chance of fixing this, which is the best view, look at it from above, which is the middle fossa approach. But transmastoid approaches have been written up. I think some doctors are more comfortable with it because they're doing more ear surgeries, but I think it's not the best approach for canal dehiscence.
So you think a middle fossa craniotomy is the best approach to SSCD repair?
Yes, that's right. And as we both started out doing, you can do a very large incision and get a very big exposure that really shows you the canal well with the standard middle craniofossa craniotomy. But we have, thanks to Dr. Yang's excellence and expertise, really been able to shrink that incision down. So I think having watched the repair and participating in it, Dr. Yang was able to say, you know, we don't really need all of this exposure. And we start to shrink the incision down to the point where it's a pretty minimally invasive incision, and the amount of bone removal is very small. That helps with healing time, it helps with operative time, and we'll show you some examples of that technique. But we're down to, I think, under 90 minutes for our surgical time routinely, and that's not hurrying or rushing, that's our standard amount of time to do the surgery.
I think our average time has actually fallen to about 60 to 70 minutes now in the past year, and we did about 60 of these last year. So you think middle fossa craniotomy is the best way to approach this? Middle fossa craniotomies are done by board-certified ENT surgeons?
There are certainly head and neck surgeons that feel comfortable doing a craniotomy. I like, obviously, your expertise. I know that you're doing more craniotomies than a head and neck surgeon would be, and if there's some problem with the approach, I know that you'll be supporting the patient afterwards, and so I feel very comfortable with you on board doing the approach and being there and supporting the patient through the pre, the surgical, and the post-operative time frame. So we do have a combined multidisciplinary view of how the surgery should be done, which is different than some other centers.
Yeah, so middle fossa craniotomies is just opening the skull, and so head and neck surgeons and neuro-otologists can do them, but here at UCLA with Dr. Gopin and myself, we use a multidisciplinary, multi-specialty, an ENT surgeon and a neurosurgeon, and the way I think about this is each one of us is doing what we do best. I do brain surgery, I make openings in the skull, and that's what I do best. I'm not an ear surgeon. The world expert and the best person and the ear surgeon extraordinaire is Dr. Gopin, and I let you do the ear repair and surgery.
I would say there are several very skilled and excellent ear surgeons, so I'm certainly not the only one that can do this procedure. But I do like the fact that Dr. Yang really supports this endeavor, and he's excellent at that approach, and I think he's really innovated the procedure to be a minimally invasive one, as you'll see from some pictures, which is nice, and I think that's why a lot of patients are coming to UCLA.
Before we get to the minimally invasive approach, once we get you down to the volcano or the SSCD, how do you repair it?
So there have been many different ways of repairing it, probably because no one way is perfect. We like to use bone wax. I like bone wax because it's very inert. It's been used since probably the 40s and 50s, so it's time tested. It doesn't react in the body, and it gives you a nice seal. So it's very much like a silly putty consistency, and we use it for other purposes, as you know, for bleeding and whatnot. And so it's a very good material for using that. If you just passively lay things on top, I don't think that gives you a good enough seal, and those are called resurfacing techniques. And then plugging the canal is something where you actually push bone wax into the opening, the lumen, and block the canal. And I do think that actually renders the canal functionless, which sometimes inevitably happens. But I think the goal should be to restore function, and some people have tried 3D printing prostheses that are put in. There's a lot of experimental stuff, but at this stage, hopefully soon things will change, but at this stage, we put bone wax over the top of the canal in an effort to try and seal it off, and then we support it with various other tissues, either a small chip of the bone flap, some fibrin glue, and other hemostatic agents to really get that repair to be nice and solid.
And the bone chip that he uses is the bone chip that I made when I made my small opening.
Right.
And so the way I think about this is that this is your own bone helping to heal yourself. It's like organic,
Sure.
Whole foods way of self-healing.
Yeah, I think that's safe to say.
So we've reviewed our patients here at UCLA, and Dr. Gopin and I, we are both associate professors in the David Geffen School of Medicine, so we're always doing research into SSCD. And this is one of our papers that we published looking at the clinical outcomes, and this is available in the Journal of Neurosurgery. All these journals here are publicly available on PubMed, and so it's really good for us to be transparent and to help publish our results so that people can learn. What do you think about the research we do in SSED?
Yeah, it's very clinically oriented. We're trying to really figure out what's going on, what's driving these patients, try and get a handle. We have a database of over 300 patients that we're trying our best to kind of keep up to date and add to it in terms of blood work and various other things that we're discovering as we go. But I think it's sort of an obligation that I enjoy, because we are one of the busier places. We have an advantage of studying these things that other smaller centers don't.
Sure. So you have a database of over 300 patients with SSED, but I know, because I help you and we do the surgeries together, we've only done a little over 190 of these canal repairs.
So those are the ones that we're following that actually don't have surgery, that are symptoms are minimal enough that they don't require surgery. I still put them in the database so we can see over time what's happening, see if their scans are changing, that sort of information.
And we talked about some of these data earlier, and then the symptoms in which you get recovery. What symptom do you think has the best chance at recovery with the middle fossa craniotomy?
So I think a lot of the internal amplification of sounds go away the earliest. So a lot of patients will wake up and those sounds are gone, or within the first few weeks of surgery, they tend to go away pretty quickly. So autophony, you can see here, is at 80%. And then I think some of the other internal sounds like pulsatile tinnitus and those sorts of things are usually the highest to go away. Dizziness is a little, maybe 3/4 is reasonable, but that depends on if it's one or both ears, and there's some other factors. Hearing is the hardest for us to fix. You can see just over half of patients have an improvement of hearing, which is, a little disappointing. You'd expect that the hearing would be better, but it is what it is. And I used to quote about a 20% chance of losing hearing, but actually now with our most recent series, it's actually well below 10% that you're actually going to lose some hearing. But I was pleased to see that the ear fullness is going away at a high rate.
What about headaches? What happens to headaches?
Yeah, it does. Obviously, you can see here 71% resolve, which is nice. I think by getting in there and putting a little padding in between the lining of the brain and the bone, you're obviously affecting that in a way that's helpful. But ultimately, what's driving those headaches is an unknown, so it's tricky to know exactly what's going on.
And this is from that publication. Those asterisks involve statistical significance, and that's just statistics that we run doing the test. What am I looking at here?
So this is the old-fashioned or a standard middle fossa craniotomy. As you can see, it's an inverted question mark, fairly large incision, and then underneath this a plate of bone is taken off that's fairly substantial. So for our first handful of patients, this is the way we were doing it. But as we discussed, you can get away with the surgery in a much more minimal approach. So I think the next slide shows this is the smaller approach, right? So you can see a small incision in front of the ear, and then it goes back on top of the ear. It actually doesn't go all the way back to there, yeah. But the good thing about this is if we wanted to, we could extend it all the way into that reverse question mark, right? So if there's a problem or if there was an issue and we had to make a much bigger surgery, we could do that. And that's why we were willing to experiment with shrinking it down. How many times have we had to convert the small incision into a large one intraoperatively during the procedure?
Yeah, we've never had to do that. And this is the onus on me, because it's my job to get Dr. Gopin down to the canal dehiscence in a safe, effective manner. He can't do his job unless I get him down there. And my job and my onus to my patients and to you and to Dr. Gopin is to get him down safely. And when he says old-fashioned, I agree. When in my residency and long ago when I was in med school, this is the way I was taught to do a middle fossa craniotomy. It's a very large C, it's a lot of head shaving, and this is a patient that came to us after they had that surgery, and once they had that surgery, we're committed to having to reuse that incision. So we went back and revised that. And then once we started shrinking this down, this is actually our second evolution of it, is that this is a U. And yeah, this U could be converted into that back one. And then in about 2014, about 4 years ago, Dr. Gopin and I, we're working together a lot. All this research we're doing together. We're in clinic together. We have the SSED Center together, the Skull Base Center together. We're in clinic together. We are seeing each other every week. And we were just trying to figure out how can we make this approach better, safer, more minimally invasive. And so 4 years ago, we came out and said, could we do this incision just through this? Could we make it minimally invasive? And this incision from here to here is a little over an inch. So that's how big the incision is. And like Dr. Gopin said, the reason why we said we can move to this is if we get in trouble and we can't find the canal dehiscence, or if there's brain bleeding, and I'm just going to talk as a brain surgeon now, if there's brain bleeding or stroke or if there's brain swelling, if there's any kind of major problem, what we can do is convert this into the old incision, or we convert this into the U. And so this doesn't take away any options. And so when we first started doing this in 2014, I thought, okay, we're gonna do this minimally invasive approach, and I bet some percentage of them, things are just gonna go wrong. Because it's surgery, it's surgery. Dr. Gopin and I, we bring our heart, our soul, we do our absolute very best every day. But God humbles me every day too, so that even though when we do everything right and perfect, sometimes things just don't turn out that way. And so we're doing this, and I just thought, you know what, when we do the small incision, there's gonna be a good number that convert to the old U or to the big question mark. And what Dr. Gopin is asking me, because he knows, is that in over 100, easily over 100 times that we've done this now, we've never had to convert to the old way. And I thought about the old way, that it was like my emergency hatch or my parachute that I would use in case this failed. But since we've converted to this, we've never had to convert to the old way. And this is what the healing looks like after a few weeks. And it's a very small incision. And we are going to show a video here to show this in this portion of how we approach SSCD. What do you think the surgical results are from our minimally invasive keyhole approach?
I think they're good. You know, any surgery has some chance, some risks of surgery, and we'll go through the risks that's different than the results. The results are reasonable. We reviewed them earlier. I would say the internal amplified sounds are the best category. You know, high, I would say 80s, low 90% range. Dizziness and balance is more like, you know, maybe 75, 80%, and then the hearing improvement is about around 50%. But the ear fullness, the headaches, that was in the kind of the mid 70%. Things that are important are, if you have it in both ears, sometimes you have to have surgery on both sides before you really see the benefit. And that's hard, especially if you're really struggling with balance after the first side. But definitely is a little rougher recovery when you have the condition in both ears than one, but that's the majority. Actually, 2/3 of our patients, when they present to us, they have the condition in both ears.
And so you think the recovery is slower when you have canal dehiscence in both ears?
From a balance standpoint, absolutely, yes.
From a balance standpoint.
Yes.
What we do, and the way we develop this minimally invasive approach, the way you can do, and you saw that old surgery, the old incision is inches long, and it's a very large craniotomy. And we do a minimally invasive approach. The incision is a little over an inch, and the opening I make, as you'll see, is about the size of a dime. And the question I normally get is, well, how do we do this? And the way we can do this is something called neuronavigation. And the one that we're using here is Brainlab. So you see that we have screens and these infrared markers that screen the patient in the middle of surgery, and that allows us to find the canal dehiscence before we even start surgery. Before I even make incision, I know where I'm going. And because I know where I'm going, I can make the incision smaller. Do you think this helps you when you do your repair?
It does. It helps us to confirm that we are where we think we are. So once you get the anatomy down and you're comfortable, you can use the navigation system to confirm what your thoughts are. But I do think it's the most helpful in really shrinking things down. So it allows us to kind of cheat ahead of time and say, hey, this is right where it's in line with, so we can make that minimal incision and not have to expand things to kind of look around. And so using modern technology has allowed us to really substantially reduce the operative time with the help of this technology.
Yeah, and so I think the multidisciplinary ENT surgery, neurosurgery, and this advanced modern technology together, it really advances the care.
Definitely.
And so this is the incision, the minimally invasive incision. This is actually just even from 2 years ago. Here, it starts here and we go here. And these days, I've been challenging Dr. Gopin because we're actually starting it about here and ending it here. So I'm just trying to make the incision as small and as minimally invasive as possible. And do you think that minimally invasive approach has an effect on how our patients recover?
I think they recover faster. Obviously, the incision's smaller, so there's less wound healing. It's just a little easier on them when they have, you know, that technique. It's sort of like an open approach to the belly versus something that's endoscopic. You're talking about less of everything, less pain, and you know, even less time under anesthesia is helpful to reduce things like post-operative nausea and vomiting, things like that. So you think
the scar is smaller?
Yes, the scar is smaller.
You think it's less pain?
Pain is reduced, that's right.
And so the wound is smaller, and so the recovery, you think, should be faster because there's less recovery to do.
Yes, our patients routinely go home, I would say, either the first post-operative day or the second post-op day, depending on how they're doing. A lot of our patients come in from out of state, out of country, so we have a worldwide practice. We've had people come from all over the world for the surgery, and the standard that we have is they tend to fly home at about a week after the surgery without problems. And so to date, we haven't had someone that has let us know afterwards that yes, when I went home a week after surgery, there was a problem. One individual had to fly all the way back to Singapore, another one had to go back to South Africa. These are long flights. And I think that's something that is important. One gentleman actually went home 2 days after his surgery to New York, which was quicker than what I think we were expecting, but he also did fine.
So I apologize for the kind of a gruesome surgical picture, but we're surgeons, and this is how that surgery is done. We make a small incision, about 1 inch in size. We find the ear canal, and if you look in the literature, this line, we've deemed it the line of Gopin, and that's what it's referred to in the literature as the line of Gopin. And this is the zygoma, and for SSCD, this line has been referred to as the line of Yang. And in the literature, that's also been in a paper, the line of Yang, and that this intersection point is where you should go down to find the SSCD with the navigation. And so this is the minimally invasive approach here. You'll see it. And that opening, it was actually from a few years ago too. It's even smaller now. It's about 1.6 or 1.7 centimeters, and the American dime, 10-cent dime, is about 1.7 centimeters. And so that's how big it is. It's a very small opening. It literally, if you put a dime above your ear, that's the size of the opening I make, and then Dr. Gopin can go down and fix it. Our surgical times have changed with this. What do you think about this?
Well, it's a good thing, obviously. So as you alluded to, it seems like it's almost a little over an hour now, which is nice. And I think that's something that's allowed us to offer the procedure to more people, so we can do a few surgeries in a day now without too much difficulty and just provide some good care.
Yeah, and so the surgical time has decreased because the incision is smaller and the craniotomy is smaller, so we can do the surgery faster. And so this is data from about 2015. This is when we made that switch. This is before when we were even doing the U, and we could see easily that our surgical times decreased. And you're right, we were averaging about 90 minutes in 2015 or 2016. But even now in 2018, as our times have improved, our averages are about 80 minutes or so, 70 or 80 minutes. I think the shortest one that we've done is somewhere on the order of 52 to 55 minutes. So we can do the whole thing in under an hour. And so this is the modification. This is the development that we developed, Dr. Gopin and myself, together here at UCLA, is taking a traditional old approach, making it a little bit smaller. And then in 2014, we developed what we call the minimally invasive keyhole middle fossa craniotomy to SSCD. Do you think you can make this surgery any more minimally invasive?
It'd be hard. We do involve endoscopes when needed, but legitimately the incision is pretty small, the opening is pretty small. Just to get in there and do a little bit of work, I think it's going to be hard to push it much past where we're at now.
Sure. You mentioned endoscopes. Here's a picture of Dr. Gopin. This is a picture that I took of Dr. Gopin operating using an endoscope during an SSCD surgery. So you can see the navigation there, and you can see Dr. Gopin, that's him there, he's a little blocked. We use a microscope, and this is SSCD surgery, a picture I took, and you're using an endoscope during SSCD surgery.
Yeah, sometimes the dehiscence is sort of around the corner. It's on the far side of the little mountain there, and this endoscope allows you to see in angles. And so the microscope is a better way to see and magnify everything, but the endoscope does allow you to see around a corner. And so for some individuals, it's nice to put the scope in there and be able to see around a corner to get the repair done a little better.
The minimally invasive keyhole craniotomy is the most minimally invasive approach to SSCD, and it's more minimally invasive than at least the endoscopic approach described in the literature.
Yeah, I think that's right.
What do you think are some difficult features? Why is SSCD surgery, why is it difficult, and why do you need that experience in repairing SSCD?
I think it's like any surgery. I think the more you do it, you get comfortable with the anatomy, you know what to watch out for, you know what is normal and what isn't. These patients have very featureless anatomy, and so the bone is very flat, and so they often have multiple little small openings in that bone from whatever the process is. And so if you think that the opening is not the correct one and you repair the wrong hole, obviously you're not going to get better symptom-wise. And so we have a number of...
Wait, so you can do a middle fossa craniotomy, whether it's big or small, and fix the wrong hole?
Sure, if you're not at the right openings. So there are multiple little openings that
There are
almost everyone
multiple
has.
openings. So they're not
Correct.
just one hole, but when you get there are several holes.
Yeah, that's right. It's almost like Swiss cheese because
Swiss
the
cheese.
bone is deteriorated, and we need to have confirmation, and that's done not only by experience but also by using these other modalities that are helpful.
Got it. And so how do you know that you're fixing the right hole?
Well, experience helps. Knowing the anatomy, making sure that you're in the right location is the crucial part with the navigation system. We also measure with a little instrument the depth on the CAT scan preoperatively and use that to confirm that we're at the right location. And then I'm pretty robust with the repair, so I want to repair not only the opening but the surrounding area to take pressure so that a new opening doesn't open up later as the condition evolves.
How do you use the external auditory canal to help you find the SSED?
Well, the external auditory canal lines up with the internal auditory canal, and we know the dehiscence is in a very set position posterior to the internal auditory canal, and so finding the external auditory canal at the first step of the procedure is easy to do, and you use that to then extrapolate where the internal canal is.
I'm not an ear surgeon, so can I just speak regular English? The external auditory canal, that's just your ear hole.
Correct.
And I should not stick Q-tips in my ear hole?
That's right.
That's what you're always
Nothing
telling me.
smaller than your elbow.
So no Q-tips.
Correct.
Got it. What do you think about the way you fix it? So we talked a lot about the way we've innovated and made the most minimally invasive keyhole craniotomy approach to SSED repair. You actually do the ear and the superior canal dehiscence repair. Talk about a little bit about your thoughts on how you repair it.
Sure. Over the years, a lot of different tissue types, as you can see on this list here, have been used. And so I think earlier on, people just kind of covered it with just a little, almost like a little carpeting. So fascia is the lining of muscle, and you can put that carpet on there. Those techniques were referred to as resurfacing techniques. And I think the problem with those techniques is they don't give you a nice watertight seal of that bony defect. And so the symptom improvement wasn't quite as good with that repair as the other style of surgery, which was that bone plugging technique. And so other individuals would actually obliterate the lumen, the opening of the canal.
Wait, so they obliterate, they plug
Right,
the canal
They plug it so that
completely.
the fluid cannot slosh through there, and they render that canal so that it's not functional anymore, but it does allow you to no longer leak sound energy, and it does resolve the symptoms in a more reliable way, but it does come at a cost of disabling that canal permanently, right? So you can't have that function from that balanced chamber if you've blocked it off.
So you block it off and completely destroy the function of the canal.
Well, if you do a plugging procedure, that's what
right.
you're doing. My goal is always to try and restore things to as close to normal as possible. And so I like to refer to it as a sealing technique. So
A watertight seal.
Right, so what I do is I take my Bomax and I try and put it as a covering, get it to seal there without necessarily blocking the lumen of the canal. And that's something that doesn't always happen. So we have looked at our own postoperative patients with MRI scans to see if that fluid signal is still sloshing around or not. And it turns out that in about 2/3 of our patients, you still have a fluid signal sloshing around. But in 1/3 of the patients, and I do the repair, as best I can, they still get blocked even though it's not my intention. And statistically speaking, the results are a little worse for balance and dizziness postoperatively. And so the patients that are struggling a little more postoperatively with their dizziness and balance are probably the ones that are getting plugged rather than just sealed. And that's something that we'll work towards trying to come up with better techniques to do that. Maybe it'll become more standard of care, but that's my thought process.
Wait, so you're saying that you always try to do a watertight seal when you repair SSED?
You have to get it sealed, that's right. If it's a very big dehiscence, pretty much it's going to plug the canal no matter what I do.
But 1/3 of the time, you actually do plugging when you repair SSED?
Yeah, for the larger ones it drops in there, or for other anatomical reasons it gets plugged.
How do you know whether you did plugging or sealing?
It is proven by the postoperative MRI scan. So the MRI scan afterwards tells me whether it's maintained or not.
So the only way to know whether you did sealing, plugging, is to get an MRI before surgery and then get an MRI after surgery?
I think if you aggressively shove the Bomax into the hole and really pack it in there, you could be pretty confident that you're plugging the canal. So I don't know that you would need to get an MRI scan before and after to prove that. But if you're trying to restore it by sealing it, yes, I think the only way to know if you're successful or not would be to do an MRI scan before and after, which is our standard.
So your goal is to try to save the function of the superior canal.
That's right. If we're successful in sealing it, we're maintaining the fluid signal we're getting the symptoms gone, but also maintaining that balance function. Particularly if it's bilateral, meaning both ears, it can be helpful to have the function without removing it on both sides.
And the way you can figure out whether or not you saved the anatomical structure and hopefully the function of the canal is with an MRI before and after surgery.
Yes, that's correct.
And your research shows that if the function is preserved, those patients have better balance outcomes?
Our research does show that, yes.
Our research does show that.
It's going to be published soon. It's not published yet, but the paper is written and we're on our way. But that's right. I think that's something that was not yet in the literature. We sort of saw that in our own data series, and we're gonna make that public.
So that if the MRI shows that the superior canal is restored and the function and the anatomic is preserved as best as possible, those patients may have better balance outcomes.
Yes.
What are some of the complications, some of the bad things that can happen with surgery?
Yeah, I think whenever you do surgery, you have to be prepared for those. Those are things that you're signing off on before you're agreeing to surgery. So spinal fluid leaks, especially in revision cases, can happen. We're under 5% for that. Usually can be repaired at the time of surgery, but once in a while we have to put a lumbar drain in. That keeps you in the hospital a little longer, 5 days. Hearing loss, we found that in about 2% of our cases. And then we were seeing a delayed facial weakness after surgery, but we were able to correlate that with a repair material that we were using to kind of glue things together that we've stopped using, and since that time we have not had any incidents of facial weakness. Those all recovered back to normal, but it obviously has been improved now that we've removed that practice.
And you presented all that research at North American Skull Base
Yes, those
Society.
were all presented papers, correct.
I get asked this a lot because it's brain surgery and it's skull-based surgery. What's the risk of dying from surgery?
Well, there's always a risk with anesthesia. Luckily, we have not had any deaths to date. It's a very, I think, serious surgery, but safe. So it is extradural. So I think people have the misconception that we're like going into the actual brain tissue. No, this is on the outside of the lining of the brain. That adds a layer of safety because you're not going into the actual parenchymal brain tissue.
Yeah, I get asked that portion a lot, which is, as the brain surgeon, am I going to move the brain? And the fact is, just like Dr. Gopin said, I never see the brain. I'm a brain surgeon doing the opening to the skull. I move the covering of the brain, but I hope to never see your brain during this surgery. I don't see your brain. I don't touch your brain. We just move the covering of the brain for this. And so we do a lot of research together. Dr. Gopin and I do a lot of research together, and we've published a lot of our research because we want to be transparent about the work we're doing, and we want to help educate. And we've had so many students and residents and fellows come through who are learning about this because we have funding for this research. And this is one publication in the Red Journal looking at how we identify the superior canal dehiscence using that navigation. This is actually research talking about using semi-automation and computerized ways to find this, so that we're using computers, we're using virtual reality. We want to use big data, machine learning, so that this becomes a better, quicker, faster, even more minimally invasive way to fix this. This is another paper that we presented together last year at the North American Skull Base Society, because I've asked Dr. Gopin, can we make this even more minimally invasive? And he's always commented back saying, if you can make that bone grow somehow, and bone is just calcium and vitamin D and hydroxyapatite, correct me if I'm wrong.
I think so.
Yeah, you can get that bone to grow, maybe through some sort of pill or injection one day in the future, in our lifetimes maybe, you could make the bone grow, and then you wouldn't need surgery to fix this. And so we've looked at bone metabolic markers, vitamin D, your thyroid levels. We've looked at this in this patient series to see how are they correlated, and this is published in the PubMed literature as well. And that this is a more recent publication, is that we have studied, like Dr. Gopin said, we were looking at patients who had decrease in hearing. And when we first started almost 10 years ago, we thought that decrease in hearing was, what percentage did we think
I
it
think
was?
20% was what we were quoting. Yeah.
We were quoting 20%, but when we looked at this, we actually found, what's the rate of hearing decrease with this surgery?
Yeah, it's under 5% now.
Under 5%. And do you think that had anything to do with the more minimally invasive surgery?
It's hard to say. Potentially there's less inflammation, so that might be one reason that it's helpful. I think the bigger opening, you're exposing things more, you're aggravating it more, and that's the theory, that you're really overwhelming the ear with inflammation and aggravation from the procedure, and that's causing the hearing loss. So I think from our standpoint, yeah, by making things a little more quick and less invasive, you are helping with that.
Yeah, and this shorter surgery time, this allows us to do more SSCD repairs in any given day.
Yes.
What's the most number of SSCD repairs you've done in one day?
I think six is the most that we've done in a single day, yeah.
I think it was 5.
I defer to your...
Okay. I just wanted to clarify because one of those cases canceled that day, so it's actually the most we've done in one day was 5.
I believe you.
But our typical average is between 2 and 4 that we do.
Yeah, I think we can comfortably do 4 procedures very easily in a day and be done before dinner time without any difficulty.
Yeah, so we do 2 to 4 SSCD repairs almost every Thursday that when we're both in town we do. Any last comments on your unique way to approach it? Is there anyone else in the country doing sealing?
I can't speak to what everyone else is doing. I do think that we discussed it pretty thoroughly. I just, very much appreciate your invitation today and a chance to discuss this condition. I think it's something that helps a lot. A lot of patients have given us very good feedback about the webinars and information that they can gather before they, come in to see us, especially when they're remote. We do offer remote teleconferences, and a lot of our information is delivered by the internet. And so I do think that this is a great idea and an opportunity, and I'm just delighted that you had me for a discussion today.
Great. It's good to discuss. Last few things. Why can't I get both sides fixed at the same time?
Well, I think that's a question you would probably be better at answering. I don't think you want to squeeze the brain from both sides at the same time. And also balance-wise, I think if you were to change things, if you're having a dysfunctional balance system and you change it and you did it on both sides, I think it'd be overwhelming for some patients. And so other risks of things like bleeding infection, I just think it would be a bad idea to do both on the same day.
Yeah. I think it also goes with Dr. Gopin's initial thought, which is if you have SSCD and your symptoms are manageable, you do not need surgery. And so I think it makes perfect sense if we do one side and you get so much better and the other side's manageable and you never need surgery again, hooray, we're rooting for you. And so that's fantastic. And so if we can do one side and be done, I think that's the best thing for the patient. That's the most minimally invasive surgery is no surgery.
That's true.
And so that's our goal is to make them smaller in terms of any other controversies or topic in the field that you want to talk about? The size and location of the dehiscents and thin bones.
Yeah, I think thin bone is ever evolving. I think that's the one that's probably worth discussing, which is if the bone is thin enough, other people have also published, you can have symptoms from that. Mm-hmm. And so we used to be very focused on whether there's an actual opening or not, and maybe the CAT scan isn't good enough. But I think if the bone is thin enough, you have symptoms. Well, how thin is too thin? That's an unknown, and so we're doing a study now where we're measuring in normal CAT scans what the normal thickness should be by decade of life, and we'll have that data to compare, and we can tell you, oh, yours is thinner than what it should be, and your symptoms are probably coming from that with a little more confidence than we can currently do.
How do you think patients do when we repair thin canal dehiscence?
They do well. Their ear doesn't get aggravated, and the symptoms tend to go away, and so I would say those are some of our stronger post-operative players. Definitely the thin bone patients have been a nice surprise in that regard. We didn't used to even offer them surgery until they actually had an opening, and I know at some centers they actually intentionally make an opening to plug it, but with our repair techniques with thin bone, we've had some spectacular results.
And so you're doing a lot of research right now in thin SSCD patients?
Yeah, thin bone, correct.
I want to thank Dr. Gopin. He is a world-class surgeon. He's one of my closest friends here at UCLA. He's fantastic, and he's really just outstanding in his surgical skill. And so I want to thank you for having me.
And I want to thank you. I think we wouldn't be here today if it wasn't for your presence, your interest, and all the work that you do on this. Not every neurosurgeon has the fortitude to take on a condition like this, and I think it really has helped to drive the procedure to be a much more acceptable one for a lot of patients. So you're really making a difference for a lot of people.
Thank you. No, I think that's really one of our strengths is our friendship and that multidisciplinary care is that you have an ear surgeon and a brain surgeon on every case together, bringing our unique personalities, our talents, and our skills. We have to thank UCLA and the funding sources that allow us to do this kind of research. And if you have any questions, you can contact me. If you are young and technologically, not everyone, but if you are technologically in tune and plugged, you can hit me, you can Twitter me, you can get me on Twitter. If you're a little older, you can get me on Facebook. Dr. Gopin, do you have Twitter?
No.
I have Twitter. You can get me on Twitter.
I'm not a Twitter.
You can get me on Instagram. You can get me on Google Plus, and we will share the information. But Instagram, Twitter, Facebook. a good way to get a hold of me. And if you're older and you want to go an older way, you can send me an email. And Dr. Gopin, you're also really readily available.
Yeah, my email's the same, first initial, last name at mednet.ucl.edu.
Yeah, so your email is just qgopin
Qgopin,
at
right.
MedNet.
Right,
And then
right.
you can call us. We're more than happy just to talk to you about this disease. As you can tell, Dr. Gopin is a fantastic doctor, a superb surgeon. And if there's anything we can do just to talk to you or discuss your surgery or do a telemedicine visit or do a second opinion about revision or repair, we're more than happy to be available to you anyway. Any final words?
Thanks again for your time. I appreciate it.
Thank you so much for visiting with us at UCLA. We'll come back to you with other webinars, and we appreciate you joining us. Thank you.
Thank you.